Assalamualaikum and good day everyone. I'm Adlinda Alip, clinical oncologist from University Malaya Medical Center. Today I will present radiotherapy in bladder cancer, what one needs to know. Okay, so these are the content of my talk today. I will start with part 1 followed by part 2. Part 1 is for both urologists and oncologists, and part 2 is specifically more for oncologists. So let's start. This slide shows the evolution of the treatment for bladder cancer. Radical cystectomy and pelvic lymphadenectomy was first described in 1949, and cisplatin was discovered in 1965 before MVAC, another chemotherapy regimen in bladder cancer, was introduced in 1985. The idea of three-modality therapy was introduced in 1993, and in 2005, ABC meta-analysis confirms the 5% 5-year survival benefit of neoadjuvant chemotherapy. And subsequently in 2016, the immunotherapy came into the scene for the treatment of bladder cancer. So what are the roles of radiotherapy in bladder cancer? It plays an important role not just in radical setting but also in palliative setting. In muscle invasive or locally advanced bladder cancer, radiotherapy is used concurrent with chemotherapy as primary treatment, and also as post-operative treatment with certain indications. In palliative setting, radiotherapy helps to relieve symptoms such as hematuria, pain from the bone metastasis, or from the actual primary cancer. So trimodality therapy consists of transurethral resection of bladder tumor, aiming for maximal debulking, followed by radiotherapy to bladder, aiming for curative dose of more than equivalent to 60 gray. And with the radiotherapy, radiosensitizer in the form of chemotherapy or carbogen was added to increase the efficacy of radiotherapy. The aim of trimodality therapy is to preserve the bladder, but at the same time for cure. Hence, the dose of less than 60 gray equivalent, i.e. palliative dose, is not considered trimodality therapy. Either does the partial bladder treatment, and patients who refuse cystoscopy post-radiotherapy should not be for trimodality therapy. So this study by Shipley et al., published in 1987, has shown the benefit of radiotherapy for patients who are unsuitable for surgery, and patients were also given cisplatin. As you can see from the graph, the 4-year overall survival was 64% for patients with T2 disease and 24% for patients with T3 to T4. So these are just for the patients who are unfit for radical cystectomy, and they gave 64 grays in 32 fraction. It was 2D radiotherapy, box field radiotherapy with cisplatin every 3 weeks. So 88% of these patients completed full dose chemo and radiotherapy, and 77% got complete response. Another study by Rodel et al., published in 2002 in JCO, included 415 patients, and this study showed complete response in 72% of the patients with radiotherapy or radiochemotherapy after transurethral resection of bladder tumor. At 10 years, 64% of those who achieved complete response maintained local control, and 42% had disease-specific survival. CCRT proved more effective than radiotherapy alone, with 10 years disease-specific survival of 45% after salvage cystectomy for local failure. And the marker for predicting complete response and survivals include early tumor stage and complete transurethral resection. So over 80% of survivors managed to preserve their bladder. So this is another study, retrospective study from Boston, and it shows that trimodality therapy gave 10-year cancer-specific survival of 59% and overall survival of 39%. The complete response rate with the chemotherapy improved from 66% to 88%, and 5-year disease-specific survival improved from 60% to 84%, and salvage cystectomy reduced from 42% to 16% with trimodality therapy. So this is another important study, BC 2001, by James et al., published in 2012. It shows the benefit of chemotherapy added to radiotherapy in terms of local regional disease-free survival, giving hazard ratio of 0.68 at 2 years. Chemoradiotherapy local recurrence-free survival was 67% compared to 54% for radiotherapy alone, and at 5 years, overall survival of chemoradiotherapy was 48% versus 35% for radiotherapy alone. So another important study from UK group led by Peter Hoskin, BCON. For this study, carbogen was used instead of chemotherapy as radiosensitizer. So this is a phase 3 randomized control trial, included 333 patients, comparing bladder radiotherapy alone or radiotherapy with carbogen nicotinamide. So radiotherapy was given as 64 grays in 32 fraction or 55 gray in 20 fraction. And the carbogen was given 5 minutes before and during radiotherapy. So nicotinamide was given up to 2 hours before each fraction. So adding carbogen nicotinamide as radiosensitizer improved 3-year relapse-free survival of 43% with radiotherapy alone to 54% with the combination, and it also improved 3-year overall survival 59% with the combination compared to 46% with radiotherapy alone. So how about trimodality treatment against radical cystectomy? So this is an attempted randomized control trial by the UK group called UK SPARE trial. However, it had to close early as they were having difficulty recruiting patients. 3/4 of patients refused enrollment. 1/4 refused cystectomy when it's randomized to surgery. So they closed after recruitment of 45 patients. With this 45 out of 1,000 aimed patients, bladder preservation was obtained in 73% of the patient. So as there are no randomized control trial that was successful, this is a simulated randomized control trial where they use multi-institutional propensity score match and weighted analysis. So a pooled cohort which would have been eligible for both radical cystectomy and trimodality therapy was matched for age, sex, stage T2, and whether they have neoadjuvant chemotherapy, and was compared. So from this analysis, 5-year disease-free survival was similar for both groups. Cancer-specific survival was also similar, 81 versus 84%. In terms of overall survival, it was better for trimodality therapy, achieving 5-year overall survival of 66% with the surgery, compared to 73% for 3-modality therapy. So how about patients with locally advanced muscle-invasive bladder cancer? So this is UK pooled data enrolling patients with T2 to T4 not positive M0, and patients either receive radiotherapy or radical cystectomy, and the survival probability was similar between the two groups. So overall survival is similar for surgery and radiotherapy, irrespective of whether chemotherapy was given or not. So trimodality therapy is a strong recommendation in many international guidelines, including EAU, so this is 2025 guidelines, and also the European Society of Medical Oncology's guidelines. For NCCN guidelines is category 1 recommendation for stage 2, and also for locally advanced or stage 3 patient. So these are the factors for successful trimodality therapy, which you can find in textbook. So patients with clinical T2 to T3, node negative, unifocal or limited CIS, they have good renal function, and they had a good response to neoadjuvant chemotherapy, no variant histology, and they had a complete TURBT. So this patient will do well with trimodality therapy. But some of these factors are also prognostic factors rather than predictive. So they will do better with these factors with surgery anyway. But we use this sometimes to guide us in patient selection. So for patients who are for trimodality therapy, do we need to give neoadjuvant chemotherapy? In fact, the ABC meta-analysis which showed the 5% benefit of neoadjuvant chemotherapy is not limited to just surgery, patients who are going for surgery. It is for any type of local treatment. It improved the overall survival from 45% to 50%. So the benefit applies to patient who's going for trimodality therapy as well. So these slides show the outcome of another trial, BA06 randomized control trial, where patient either they had surgery or radiotherapy alone, or versus with neoadjuvant chemotherapy, and the 10-year overall survival probability shows benefit of neoadjuvant chemotherapy with both radiotherapy or surgery, giving hazard ratio of 0.8. So you can see from the EAU guidelines in 2025, neoadjuvant chemotherapy is one option for patients with T2 to 4A and not M0, alongside radical cystectomy or trimodality therapy. Okay, so these slides show the useful factors that may favor one treatment over the other. So on the top left corner, patient who had poor bladder function, inflammatory bowel disease or previous radiotherapy, diffuse CIS or multifocal tumor are factors that may favor radical cystectomy. Patient with good performance status, unifocal T2 stage, no hydronephrosis, no multifocal CIS are factors that favor both radical cystectomy and trimodality therapy. Patients who are high surgical risk and those who desire to preserve bladder function, these are the factors that favor trimodality therapy. Unfavorable prognostic factors for both surgery and radiotherapy or trimodality therapy include multifocal tumor, diffuse CIS, poor performance status, poor renal function, and hydronephrosis, plus patient with T3 and T4 disease. So basically for trimodality therapy, patient selection include those with non-metastatic muscle-invasive bladder cancer. They have strong desire to preserve bladder. They have good bladder function at baseline, and they are medically unfit for cystectomy. These patients should be willing for cystoscopies on follow-up. They are compliant to follow-up, and they accept the possibility of salvage cystectomy in 10 to 15%, and they accept risk of surgical complications of salvage radical cystectomy. So these are my take-home message for the first part. Survival is similar for radiotherapy compared to surgery across T2 to T4 and not to N1 disease. Quality of life well preserved. In terms of sexual domains, radiotherapy is better than radical cystectomy. Patients who are fit should be given neoadjuvant chemotherapy, and trimodality therapy is offered to good responders. Patients should be motivated and compliant to follow up. Concurrent radiosensitizer to optimize efficacy should be given. And with trimodality therapy, successful bladder preservation is seen in 70 to 80%. So radiotherapy to the bladder can be given as 3D conformal radiotherapy technique, or using IMRT or VMAT technique. And in terms of radiotherapy, there are variations. Some centers give whole pelvis, even in node-negative disease, and other centers give radiotherapy to bladder only when it is node-negative. So technique of radiotherapy has evolved over the years. In the past, 2D conventional radiotherapy was given with 4-field box technique. Subsequently, IMRT or VMAT was introduced, and more recently, online advanced adaptive radiotherapy is being used. There are also different schedules. Traditionally, 64 grays in 32 fraction was given to the bladder, and if pelvic lymph nodes is covered, those up to 50 gray was used. But many centers still just give radiotherapy to bladder only, with no irradiation to the pelvic nodes if it's node-negative disease. And some centers do give 54 gray in 20 fraction, even with concurrent radiosensitizer. And for frail patient, 6 grays times 6 has been used weekly for local control. So in terms of dose fractionation, which one is better? So BC 2001 and Beacon randomized control trial from UK actually allowed both fractionation, 64 gray in 32 and 55 gray in 20 fraction. So what they did was so when they analyzed the two studies, and in combination, they found that local control is better with hypofractionation, but overall survival is similar between the two, and late toxicity was found to be similar with either fractionation. So this slide shows the experience from Tata Memorial, where they transitioned from the dose 64 gray in 32 between 2014 to 2020 to 55 gray in 2021 to 2023. So they actually give pelvic radiotherapy, not just bladder. And what they found was there was no acute grade 3 toxicity. Grade 2 GI acute toxicity is higher in the hypofractionation group, but late toxicity was similar. So 2-year local control was 89%, disease-specific survival of 88% and overall survival of 85%. And this study from UK is a phase 2 trial, RADAR, where they look at the whole bladder radiotherapy, either 64 or in 32 or 55 in 20, compared to standard adaptive radiotherapy or dose escalated adaptive radiotherapy. I will discuss this further later. So the question is whether we should give bladder only or whole pelvic radiotherapy for and not disease. So this is a single center randomized control trial from Pakistan involving 230 patients. They gave 45 gray in 25 fraction to the whole pelvis or bladder only, and added 20 gray to the in 10 fractions to the bladder. And what they found was there's no difference in terms of outcome when they look at overall survival. So this is another study from Canada where they pulled 599 patients and compare whole pelvic radiotherapy and bladder only. And what they found was, in terms of cancer-specific survival, the whole pelvic radiotherapy gave advantage, giving hazard ratio of 0.66. The prognostic factor for both cancer-specific and overall survival that they found in the study include pelvic radiotherapy, of course, good performance status, T-stage, hydronephrosis, and neoadjuvant chemotherapy. So, do we need to treat the whole pelvis or not? So, the arguments for bladder-only radiotherapy include the randomized control trial was negative. The bladder-only radiotherapy in BC 2001 and BCON trials gave a good outcome. The node-only recurrence in the study was less than 10%, and there are bowel toxicity concern in terms of including the pelvis. So the arguments for the whole pelvis include data are unreliable from the only randomized control trial. The whole pelvic radiotherapy included in all RTOC trials. The benefit of pelvic RT has been seen in modern large series. If there are nodal recurrence, it's often unsalvageable, so better to treat up front. And the toxicity from especially the bowel is mainly grade 1 to 2. So we can consider to omit pelvic radiotherapy in T2 to 3A, perhaps treat mini pelvis, but patient with T3B to T4 or not positive, they do need pelvic radiotherapy up to aortic bifurcation. Okay, in getting a good planning for bladder radiotherapy, optimal planning CT need to be obtained, focusing on bladder and rectum filling. Patient education is very important. CTV, i.e. the bladder, is delineated on the CT, and MRI can be useful, especially to delineate the caudal part of the bladder. If possible, GTV is delineated using TURB description and also CT. And in terms of margin for movement, there would be larger movement in anterior superior direction compared to lateral, inferior and posterior, so different margin can be used. And RTOC atlas can be used to delineate the organ at risk and also the lymph nodes in the pelvis. The challenges in radiotherapy of bladder cancer include the geometric uncertainty of the target throughout treatment, because bladder is highly mobile and deformable with different with variation in bladder volume, shape, position, influenced by the bladder filling and movement of the other nearby organs within the fraction or interfraction. And in terms of population-based margin, is often large, giving unnecessary normal tissue irradiation and increased toxicity, and there could be a geometric miss. So the advancement in terms of radiotherapy for bladder cancer is more towards adaptive radiotherapy. So there are plenty of publication on this. So we can see from non-adaptive radiotherapy, from the planning image, PTV margin is added, and when we review patients in terms of image guidance radiotherapy daily treatment, we can see the target, i.e. the bladder, changes in size, and also in terms of the shape. Okay, and patient might receive unnecessary radiation when the bladder is small, as you can see from the image on the further right. So with non-adaptive radiotherapy, PTV margin of 2 cm is used for anterior and superior direction, and 1.5 for posterior, and 1 cm for inferior and lateral. Okay. MRT or VIPMAT technique is usually used with simultaneous boost to the bladder or elective nodes. CBCT is done daily, and initially a bone image was used, followed by soft tissue evaluation. Fiducial markers has been looked at with uncertain benefit at this point. So adaptive radiotherapy refers to the modification of radiotherapy plan to account for changes in patient's anatomy, for example, tumor shape and bladder filling. It aims to deliver the prescribed dose to the target with high precision and accuracy while reducing margins, hence limiting normal tissue irradiation. So according to the Royal College of Radiologists, there are 4 categories of adaptive radiotherapy, whether it's reactive, scheduled, or the online adaptive radiotherapy, including the proactive and real-time. So the proactive usually use appropriate treatment plan chosen from the library of plans called plan of the day, or the real-time is when the plan is generated at the time of the treatment after daily pre-treatment imaging. Okay, so this is to illustrate patient would have a few fractions for the first week, and then from this different target, different plans will be produced and saved in the library, and during treatment, depending on the shape and size of the target, different plans can be applied. So this is one of important trial. It's a phase 2 trial looking at adaptive radiotherapy, whether it's just the whole bladder radiotherapy or the adaptive standard radiotherapy, and also the dose escalated adaptive radiotherapy. So these are the results from the radio trial comparing the standard bladder radiotherapy to the adaptive radiotherapy. The standard radiotherapy to the bladder actually achieved similar results compared to the previous published studies of PC 2001, giving local region control of 65% at 2 years and 80% of invasive local regional control at 2 years. Dose escalation achieved, if confirmed, give clinical meaningful benefit with improvement of 9% and 4% of 2-year local regional and invasive local regional recurrence rates. Difficult to compare with cystectomy series, as there are inherent selection biases. The 5-year overall survival was 66% from the cystectomy series and 80% at 2 years, which is similar to the rates observed in Raider, which are mostly older, less fit cohort with median age of 73 in Raider compared to 71 in the systemic series. 4% of the patients from the Raider trial have had to have cystectomy, similar to previous escalation studies. And this actually is much more favorable compared to previous report from BC 2001, which gives a rate of 14% of cystectomy following the TMT treatment, and the series from Boston gave 29% rate of cystectomy. So these are the organ at risk constraint for 64 grays in 32 fraction from the Raider trial. And these are the constraints for the 20 fraction schedule, which you can refer to. This is another study from Denmark. So what they did in this study for the adaptive radiotherapy is they do the standard non-adaptive treatment for fraction 1 to 5, and from there in that treatment they added margin as per shown, 20 centimeter anterior superior, 1.5 centimeter posterior, and 1 centimeter inferior and lateral, and they give a margin of 8 millimeter for PTV superior inferior and 5 millimeter to other directions. So after 5 fraction, they created 3 plans, small, medium, and large volume, and according to the image required daily, they will select one of these 3 plans according to the bladder shape and size. So they give PTV margin of 5 millimeter for the adaptive radiotherapy plans. So you can see the different shape and volume of the target, and the different plans that they use. Red is the large volume, the green is the medium, and yellow is the small volume. So again here, how they created the library of plans is they do the initial planning on the planning CT, and then the first 4 CBCTs. So and then they group together the target as small, medium to large. So the small volume contain at least 2 of the 5 CTVs. The medium are the union of the whole 5 CTVs, and the large is the standard non-adaptive margin used. So this is from the So the study concluded that they managed to reduce the irradiated volume by 30 to 40% and reduce dose to healthy tissue. Adaptive radiotherapy, and different trials showing favorable grade 2 diarrhea using adaptive compared to non-adaptive therapy. So how about real-time adaptive radiotherapy? So from these slides, you can see patient 1 and patient 2 using online versus offline, just IGRT. So in terms of PTV volume reduction, you can see 50 versus 36%, and the dose to bowel and rectum reduced with real-time adaptive therapy. So this flow showing how the real-time online adaptive radiotherapy is being implemented. With the initial treatment planning scan, reference plan is being made, and during the daily treatment, image is acquired. With the image, it will be reviewed. So the organ at risk and the target is being looked at and recontoured as necessary. First with the use of AI, and then either the radiotherapist or the clinician will review and edit as necessary. From here, it will be compared to the reference plan, and either the new plan is being recalculated or re-optimized to be the adapted plan, and then treatment will be delivered. And with this online real-time adaptive radiotherapy, the median time after patient is set up to the treatment, it will take up to 14 minutes. And they found that there is 34% in terms of volume reduction, target volume reduction with the real-time adaptive radiotherapy. And in terms of bowel bag, rectum, for bowel bag is 19% median reduction of V45 gray, and for the rectum 71% of V50 gray reduction. And adaptive plan was selected in 99% of the fraction, and improved target coverage was found in the adapted plan. So actually, in some centers, the CBCT-based online adaptive radiotherapy is being run by the radiographer actually. So they evaluate and edit the influences, and also which is the organ at risk, and also the target, and then they evaluate which treatment plans. They evaluate the treatment plans using the AI system as well. So they run the entire workflow, and physician and physicist just present at the first fraction, and only if needed thereafter. But they do check weekly the offline review. So MRI is another modality used for online adaptive radiotherapy, and the new sort of direction is looking at GTV focus radiotherapy, so reducing dose to the rest of the bladder. So this is still under study. How about adjuvant radiotherapy? So for selected muscle-invasive bladder cancer, the reason why we give adjuvant radiotherapy is to prevent local regional relapse, as it was found to be frequent, and it can be as early as less than 18 months after surgery, and it carries poor prognosis. Usually radiotherapy is given to the systemic bed as well as the pelvic area, which is now the new consensus for the target. And who do we give radiotherapy to? Patient with TT3 to 4A disease, especially if they have node positive or margin positive. So we give radiotherapy to the whole pelvis up to 50 gray using modern IMRT technique. And radiotherapy, if nivolumab is given, radiotherapy is given before the adjuvant nivolumab. However, meta-analysis for the benefit of adjuvant radiotherapy is still need to be done to confirm the actual benefit. So my take-home message is for this part is bladder is mobile and deformable, hence strong case for adaptive radiotherapy. The local control for bladder cancer with radiotherapy is good. Dose escalation seems to be feasible, but most recent advancement is more towards effort to reduce side effects to organ at risk with adaptive radiotherapy. With that, I thank you.